program of Delhi CSI, and we are into the 29th webinar today. And this webinar has brought a lot of benefit to thousands and thousands of residents across the country and the globe. And today we are having a wonderful breakout session on atrial fibrillation management. So we'll be taking these controversies and current perspectives in management of very common disorders. So today we have the privilege of having Dr. Nitish Naik, Professor of Cardiology and Electrophysiologist from All India Institute of Medical Sciences. And on the panel from the GV Pant Hospital, we have Dr. Naik Gupta, Associate Professor. From the Safdarjung Hospital, we have Dr. Ankit Bansal, Associate Professor of Cardiology, and Dr. Sanjeev Kathuria, and along with me, my colleague, Dr. Girish MP. So over to you, Dr. Sumod, for starting this session. And in case you have any questions, clarifications, and doubts regarding the atrial fibrillation management, practical questions, practical problems that you face, please feel free to write to us in the chat box. We'll be very happy to take these questions in the end with the panel so that all the clarifications and all the doubts are cleared. If you want to write something, listen to some speaker, want particular topic to be addressed, please mail it to us on pgtrack@gmail.com. And in case you miss out this lecture, please don't worry, because this particular talk will be available on the YouTube channel of the PG Track CSI Delhi branch, which I'll be sharing soon as a link to you. So over to you, Dr. Samod, for inviting our speaker and starting this session.
Once again, a very warm welcome to this Delhi CSI PG Track program. Today we have another interesting topic on atrial fibrillation. And as we all know, there are so many controversies in that topic. When to aggressively pursue for rhythm control, when rate control is sufficient. We have so many newer anticoagulants available, when to use them, what is the right newer anticoagulant to be used. So many questions we all are having. And today to teach on this topic, we have an excellent teacher, Professor Nitish Naik from All India Institute of Medical Sciences. Sir is an excellent teacher, especially sir is very clear in his concepts, and it's a great delight to always hear him teach. So it is, and we all look forward to hear from such teaching today. Sir, please come and teach on this topic of atrial fibrillation.
Thank you, Sumod, for your very kind words. And I'm really thankful to Dr. Mohit for inviting me here. So I thought it would be good to discuss on some of the newer advances that have happened in the field of atrial fibrillation and see how it impacts our everyday practice and our everyday handling of patients. So I'll start with the talk. Can I share my slides, please?
Yeah, please, sir.
Yes. Thank you. So are my slides visible?
Yes, sir. Please go ahead, sir.
Okay. Thank you. So as we know, right now, when we look at a patient with atrial fibrillation, there are 4 things that we have to look in detail. And many of the things that I'll be talking are derived from the current guidelines of ESC, which all fellows are expected to know. Since these guidelines are very exhaustive and they cover a lot of things, I have tried to break down some of the controversies and some of the new things that have happened in the past few years for your benefit, so that you can relook at them in the right perspective. So when you look at these patients with stroke, with atrial fibrillation, understand the thing that should strike you most importantly is, how do I manage this patient? And when you look at rhythm, when you look at management, it's not only rhythm management, it's also to assess the patient's stroke risk. It's to look at the understanding the severity of the symptoms, how much is the AF burden, and substrate severity. All these are important because AF is very different from all other arrhythmias. It's not like a yes or no arrhythmia that you have atrial fibrillation one day and you don't have atrial fibrillation other day. It's quite different from all other rhythm disorders, and therefore your approach to managing a patient is quite different from the yes or no diseases like an SVT or idiopathic VTs. So that's why, in fact, if you look at the guidelines, the first cogwheel they say that is important in management of a patient with atrial fibrillation is assessing your stroke risk. So that's one of the things that we'll do in the seminar, look at assessment, how well can we assess the risk of stroke in a patient with atrial fibrillation. Now, when it comes to actual management, obviously you have to understand how your anticoagulants play the most important role in preventing future strokes, and you need to understand how you assess the patient's stroke risk and what drugs to give. You need to decide how to manage the symptoms, whether you need to give a rate control strategy or a rhythm control strategy, and obviously need to understand all the risk factors that could be contributing to his recurrences for atrial fibrillation. So all these three things become key cogwheels are extremely important in the therapeutic choices that you exercise when treating your patient with atrial fibrillation. Now, how do you assess the stroke risk in atrial fibrillation? We all know that patients with valvular AF are at very high risk for stroke, and therefore these patients should be all receiving anticoagulation. When we mean valvular atrial fibrillation, we mean patients with both mitral and aortic valve disease who have got significant valvular lesion, especially patients who have got mitral valve disease. But when patients do not have valvular atrial fibrillation, that is, which is the most common form of atrial fibrillation, the most commonly used score is the CHAS2-VAS score. And you know what the CHAS2-VAS score comprises of. It comprises of LV dysfunction or history of heart failure, hypertension, age more than 75, a diabetic, a previous history of stroke, of TI or peripheral embolism, presence of any vascular disease, for example, peripheral arterial disease, or female sex. Now, female sex is not really a risk factor. It is only a risk modifier, and it does not add to the increased risk of stroke greatly. So it's just a modifying factor. It's not a great risk factor. And depending on the CHAS-VAS score that a patient accumulates, the risk of stroke increases. And as you can see, a meaningful increase in the stroke risk happens only when you accrue a score of 2 or more. I think so. I'm sharing. I'll have to just escape and see if I'm sharing the right set of slides or not. Just 1 second. Just 1 second. Am I audible now? Are my slides visible?
Perfect.
Yeah, I'm sorry. There was some error in the presentation. So you should recognize that the incidence of stroke varies according to presence or absence of atrial fibrillation. And as you can see, atrial fibrillation increases the presence of atrial fibrillation nearly increases the risk of stroke nearly by 5-fold. In fact, AF accounts for a quarter of all strokes. And in a quarter of all strokes, in a quarter of patients, strokes may be the initial manifestation of atrial fibrillation. So that is the extent to which atrial fibrillation may be responsible for stroke. So when you look at the risk of stroke, we just saw that patients of valvular atrial fibrillation are at increased risk. Non-valvular patients are also at increased risk on what we use as the CHA2DS2-VASc score. But remember, female sex is just a modifier, and a significant increase in the risk of stroke happens when the CHA2DS2-VASc score crosses 2. And that's when the risk of stroke is sufficiently high that you should be considering anticoagulation. But this is what is conventional thinking, that a risk score of 1 or more seems to identify patients at low risk for stroke, and a score of 2 or more seems to identify patients at a risk that is significantly higher. Now, this is something which is a little controversial as of today, because there are other things that we'll see in the subsequent slides which modifies a patient's risk for stroke. Now, why this is a controversial factor is that this CHA2DS2-VASc score, which identified all these clinical markers and all, was based on studies that were done more than 20 years ago. And these trials had the patients from which the score was calculated actually randomized less than 10% of the patients screened. These were the patients who were not being treated with anticoagulants then, and that is why you could understand how much each risk factor contributed to the risk of stroke. But the problem with the scores was that many of the other risk factors which can contribute to the risk of stroke were actually not even measured. Or if they were measured, they were not consistently defined. And as a result of which, many other risk markers that we see in everyday practice, for example, left atrial size, maybe spontaneous echo contrast, maybe renal failure, or they are not even mentioned in the score, which actually which are responsible in, we know very well can be considered as risk markers for atrial fibrillation. In fact, if you look at the studies, if you look at when they identified LV dysfunction, there were 18 studies that looked at LV dysfunction as a risk marker for stroke, and 7 of them there was a positive correlation of LV dysfunction with the risk of stroke. And similarly, you can see that the number of studies that identified each of these parameters as a risk marker is given in this table. And you can see the number of studies were small, they were very old, and many of the important risk markers that we assess in our imaging or clinically or by biomarkers were not considered when they were calculating the risk of stroke. And what are these other clinical markers? For example, we know that patients with CKD who have got renal dysfunction are at risk for stroke. We know that people with sleep apnea, it's an important modifier for presence of atrial fibrillation, hypertrophic cardiomyopathy, other degenerative diseases, metabolic syndromes, and in echo, like we just discussed, SEC or low left atrial appendage velocities. Presence of aortic plaque is not even mentioned as a risk marker in the CHA2DS2-VASc score. Presence or absence of small vessel disease, which in an elderly can increase the risk of stroke, is not mentioned. And many of the cardiac biomarkers, which look at inflammation, or which look at cardiac biomarkers, or they look at heart failure, or they look at thrombosis, none of them are featured in the CHA2DS2-VASc score. Which is why, if you look at all these biomarkers as an associated marker for atrial fibrillation, you can see that when studies of the past 2 decades are analyzed, many of these risk markers have had a positive correlation with stroke, with mortality, and even with major bleeding. And the reason for that is atrial fibrillation is just not a rhythm disorder; it's a sort of a cardiomyopathy. It has practically got syndromic associations, and therefore there are a lot of risks. There are a lot of systemic illnesses which can contribute to the outcomes related to atrial fibrillation, and therefore all these are not assessed adequately with the CHA2DS2-VASc score. In fact, one of the recent scores that which seems to be a promising score is the ABC stroke score, which includes all these parameters of including age as a continuous variable. It uses NT-proBNP and cardiac troponin, and includes the history of prior stroke or TIA to assess a stroke risk, and also uses a similar but different parameters to look at bleeding score. And with this score, which has been used in many of the contemporary trials, they have shown that you can get a better assessment of the patient's probability of having a stroke, systemic embolism, than with the usual CHA2DS2-VAS score. In fact, in the usual CHA2DS2-VAS score, it is important to note that you use an age, a limit of 65 to 75, whereas it has been very well shown that in Asian population at least, the risk of stroke starts increasing from the age of 50. So therefore, if you look at this score, which includes a stroke, which uses age as a continuous variable, your risk of having an embolism starts rising from somewhere in the 50s. And therefore, in this sort of a stroke score, may be something that we may see more often in the years to come, because this is more useful for identifying patients at who come in a CHA2DS2-VAS score category of 0 to 1, because that is a category that is not very well characterized as of today. Now, there are some things that add to the risk of stroke beyond just CHA2DS2-VAS score, and that one of them is left atrial morphology. Now, we know that if you look at the left atrial morphology, these are CT and MRI images of patients with left atrium who do not have any other structural heart disease. And if you note, nearly half of us would have a left atrium that has a typical chicken wing morphology, and other half would have a left atrium that either has a cactus-like morphology, a windsock, or a cauliflower type. The cauliflower is the least common. About 5% of people have cauliflower type. Cactus would be in the range of 20-30%, and windsock would be by, I guess, about 15-20% also. So if you look at patients who have got a chicken wing versus a non-chicken wing morphology, the risk of stroke is high in all these three morphologies, and therefore this is another thing that may be useful in when you are trying to define the patient's risk for stroke in the assessment of atrial fibrillation. The other thing that can affect the patient's risk of stroke beyond the usual CHA2DS2-VAS score is the presence or absence of atrial fibrillation. For example, if a patient has got a low CHA2DS2-VAS score, but he has been in atrial fibrillation for quite some time, then it's likely that this patient would have developed some sort of a cardiomyopathy. And it has been shown that if you do cardiac MRI, and these are special cardiac MRIs, these are not the routine cardiac MRIs that we do in everyday practice. If you look at the cardiac MRIs in these patients, there is evidence of fibrosis. And this is the fibrosis that contributes to the loss of contractile function of the left atrium, and therefore elevates the risk of systemic embolism. So patients who have, and this is classified using various scores. UTA score is one such score that has been used, and has been shown that patients who have got a UTA score of stage 4 score, then these patients are the ones who have a high risk of thromboembolism, even if their CHA2DS2-VAS score is very low. Therefore, this is some of the newer developments that we should consider, especially when we are looking at patients with seemingly low risk for atrial fibrillation on a CHA2DS2-VAS score. Now, the third thing that is very important in our assessment, and this is what has been taught to us by all of us who are doing cardiac devices, is the importance of subclinical atrial fibrillation or atrial high rate episodes that are seen on the Holter monitor or in any other rhythm devices. Now, I'm sure all of you must be getting consults for patients who have got smartwatches and who may call you up and say, hey, doc, my smartwatch showed an atrial fibrillation episode. What does this mean for me? Now, and similarly, you must be getting any number of calls from your neurology colleagues or neurology wards, where the neurologist says that this guy's had a stroke. I've got a Holter on this patient, which I ordered, and my Holter showed that this patient has had 3 hours of atrial fibrillation. Should I give him an anticoagulant? Now, this is something that is a very complex decision, and you should understand that why are your neurology colleagues or your medical colleagues or your other friends confused about the importance of subclinical atrial fibrillation. Now, you must have all read about this ASSERT trial, which was published many years ago. I think so, maybe about a decade back or so, or even longer. And what the study showed was that these were patients who had not got any sick sinus syndrome or underlying atrial fibrillation or any atrial tachyarrhythmias. They had been given cardiac implantable devices. They had been followed up, and they looked at whether they had evidence of subclinical atrial fibrillation. And what the study showed was that in patients who had subclinical atrial fibrillation diagnosed on a cardiac device as an atrial high rate episode that was more than 6 minutes and which was often confirmed by another monitor on the ECG, on another device like a Holter, when they showed that these patients had atrial high rate episode more than 6 minutes on these devices, the probability that this patient in the future would develop a cardiac arrhythmia, like atrial flutter or atrial tachycardia or atrial fibrillation itself, was much higher when these arrhythmias were not present. So and there you can see the graphs diverge. If you didn't have subclinical atrial fibrillation on your cardiac device, the probability was less than 0.05%. But at the end of 2-3 years, on the other hand, if you did have atrial high rate episode demonstrated on your cardiac device, the probability was anything between 15 to 20%, which was quite notable. And what they showed as well is that the risk of stroke was also higher in patients who had subclinical atrial fibrillation. And this not only stroke, they could even have peripheral embolism. And the discriminator at which the risk of stroke or systemic embolism increased was 6 minutes. And the CHA2DS2-VASc score of these patients was 2.2, and the stroke risk was something like 1.5% per year. Now, normally, as we just saw, at a CHA2DS2-VASc score of about 1.3% per year, you would not give anticoagulation, but this study suggested that patients should be given anticoagulation, which because a 1.5% per year risk of stroke is a little low. But yet, this is what caused confusion, and now many neurologists are very happy to provide anticoagulation if they see a Holter which shows an AF of 6-7 minutes. And remember, this was a single episode of atrial fibrillation, not a cumulative episode of 6 minutes documented over the period of the Holter recording. But when this study was reanalyzed, and this was published just a few years ago in European Heart Journal by the same authors, by Dr. Stuart Connolly and others, and this was published in 2017, what they showed was that the actual difference in the risk of stroke was not seen in patients who had atrial fibrillation lasting from 6 minutes to 24 hours. The actual rate of stroke was very, very low and similar to the risk of stroke comparable to a population that didn't have subclinical atrial fibrillation. As you can see, all the three graphs overlay, and the only group that made a difference in the probability of having atrial fibrillation or of having a stroke was in patients who had subclinical atrial fibrillation that lasted more than 24 hours. And so as you can see, in these patients, the risk of stroke, clinical stroke, was about 3.1% per year, which is what you would prescribe anticoagulation for. So this was something that I think is a very important message for us, that you should not be prescribing anticoagulation to patients who have got atrial fibrillation that is lasting briefly, say 5 minutes, 10 minutes, 15 minutes, even an hour, 2 hours, 3 hours, 4 hours, 5 hours. It doesn't increasingly change the risk of stroke or systemic embolism. In fact, what they showed was that that as the risk of as the duration of these episodes increase, the probability that these patients would actually manifest as clinical atrial fibrillation also kept increasing. For example, if you didn't have subclinical atrial fibrillation in your cardiac device, the probability that at the end of a year that you will develop clinical atrial fibrillation was only 3.7%, and this is obviously the risk of atrial fibrillation that is there in any population at any particular age. If you had atrial fibrillation lasting between 6 minutes or 6 hours, the probability that you would actually develop clinical atrial fibrillation was about 8-9%, and with increasing duration of atrial fibrillation, the probability became higher. But nevertheless, the advantage of anticoagulation emerged only in people who had atrial fibrillation lasting more than 24 hours. And this is what has been seen in many other studies. Was a pooled analysis that was published recently again in Europe in the Heart Rhythm Journal. This looked at 3 studies, and they had nearly 6,500 patients. I'm not sure. I think it was the trend study and a couple of other studies whose data was analyzed. And what they showed was that although the transition to atrial fibrillation happened increasingly uh, with higher category of underlying atrial fibrillation. For example, if you had 5 minutes to 1 hour of atrial fibrillation, the probability that you will develop atrial fibrillation lasting more than 24 hours at the end in 6 months was only 5%. But on the other hand, if you had atrial fibrillation that was lasting between 12 hours to 23 hours in your cardiac device, the probability that you would have atrial fibrillation that lasted more than 24 hours was more seen in more than half the patients. So as atrial fibrillation progressed, silent atrial fibrillation, the chances of developing clinical atrial fibrillation increased. But nevertheless, even if the atrial fibrillation did become manifest, the chances that somebody would have a stroke remained low. For example, if you had, let's say, atrial fibrillation lasting more than 24 hours, but your CHA2DS2-VAS score was up to 2, the probability that you'll have a stroke was still very low. Therefore, the therapeutic advantages of prescribing anticoagulants was not there, even if the atrial fibrillation, silent atrial fibrillation was lasting even 24 hours if your CHA2DS2-VAS score was low. And if your atrial fibrillation duration was lower, even say 6-7 hours of atrial high rate episode lasting 7 hours, 8 hours, and your CHA2DS2-VAS score was even 3 or 4, the probability that an anticoagulant would be useful in preventing a clinical stroke remained quite low, which is why the current guidelines, which are there in the ESC, clearly state that when you discover subclinical atrial fibrillation, you have to tread cautiously. It's not like you can prescribe anticoagulant left, right, and center. You need to assess closely this patient. What is the burden of atrial fibrillation? You have to look as whether he actually develops atrial fibrillation. You have to calculate his CHA2DS2-VAS score, and only then would you be helping this patient by prescribing an anticoagulant. And therefore, this is a very important thing that I guess all of us should know, that the therapeutic utility and net clinical benefit of prescription of anticoagulation comes in only when the atrial fibrillation duration is long, and that is coupled with a high CHA2DS2-VAS score. So now we'll jump track and go to rhythm control controversies. Now, I think so rate control of all of us know reasonably well. Now, in rhythm control strategies, the most important is which drug to use. And whenever you initiate any therapeutic regime, you know that the drugs are a little toxic. And whenever you're using these drugs, you need to use them cautiously. So before you take a decision for initiating antiarrhythmic therapy, you need to make sure of a couple of things. And the first thing is the patient symptomatic. And if he is symptomatic, is he sufficiently symptomatic? And how do I understand whether he's sufficiently symptomatic? Now, the best way to do that is this sounded like a great way, the EHRA score, in which you can classify that score into 1, 2, 3, and 4. And these are reasonable, simple ways that we can look at the patients in our cardiac OPD. And once you've decided that the patient has moderate to severe symptoms, only then should you be deciding that whether this patient would be benefiting from a rhythm control strategy. Because remember, an antiarrhythmic drug is only being used. The entire aim of prescribing an antiarrhythmic drug is to improve symptoms. Its efficacy, remember, the efficacy of using an antiarrhythmic drug to convert atrial fibrillation to sinus rhythm is modest. It will only reduce rather than eliminating the occurrence of atrial fibrillation. These drugs always have important interaction and they are pro-arrhythmic, and therefore safety will always override efficacy. So the entire indication of initiating antiarrhythmic therapy is to improve symptoms, and therefore when you do it, make sure that you feel confident that the patient is really symptomatic before you start prescribing these drugs. Now, what should you do when you want to, how do you assess the patient is important. You need to understand whether this patient has got coronary artery disease, because that is an important no-no to the important antiarrhythmic drugs that we use in our practice. You need to rule out other structural heart disease as well, including hypertrophy or congenital heart disease. You need to look at his ECG closely. You need to look at his QRS duration, his PR intervals, QTC intervals, whether does he have sinus node dysfunction or does he have AV blocks. And even after you prescribe this drug, remember that you'd have to reassess the ECG after 1 to 2 weeks, depending on the dose that you're prescribed to this patient. You clearly need an echocardiography. And more importantly, when you prescribe an antiarrhythmic drug, remember that a periodic reassessment is mandatory, because remember that in a quarter of patients on whom you start antiarrhythmic therapy for atrial fibrillation, their CHA2DS2-VAS score actually changes over a period of time. And many studies have shown that nearly 20 to 30% of people within the first year change their status. Patients may develop LV dysfunction because of atrial fibrillation. Patients may have a stroke or TIA, and therefore your entire therapeutic decision may change based on the patient's follow-up. Now, which are the drugs that you would like to use in a patient with atrial fibrillation? Now, clearly the one that is useful that has shown the best efficacy in converting atrial fibrillation to sinus rhythm is, flecainide and propafenone. Now, flecainide, both of them are toxic drugs. Both of them were used in the CAST study, and they were shown that they increase the risk of arrhythmic death. So you need to be very careful when you're prescribing these drugs. Patients who have got coronary artery disease or who have got heart failure with reduced ejection fraction of less than 40%, liver or kidney disease, hypertrophy that exceeds 15 millimeters, or even prolonged QRS, you should be very careful before you prescribe flecainide. In a patient who has got only atrial flutter, you should be also very cautious in prescribing flecainide, because flecainide can slow this atrial flutter and make that flutter conduct 1-to-1. Therefore, you should be doubly sure that your patient is adequately beta blocked before you introduce flecainide. In patients who have got sinus nodal disease or AV conduction disease or any other conduction system disease, including left bundle branch block, you should be cautious in prescribing flecainide, because supposing he has, say, LBBV and a QRS duration of more than 130, I wouldn't be comfortable prescribing flecainide for such a patient. The dose generally is 50 to 200 milligram. And the main side effect that you need to look for is bradycardia, or if the QRS duration increases by more than 25%, or if the QRS ever increases to more than 150, it's an absolute no-no to prescribing flecainide. The same holds true for propafenone. The only thing difference in propafenone is that propafenone can occasionally worsen asthma. So if your patient is asthmatic, be a little cautious in prescribing this drug. The maximum dose that you can prescribe a patient is 300 milligram TDS. I know that in India, we are using much lower doses. We are using doses from about 300 milligram per day to obviously 600 milligram per day. But yes, you can go up to 900 milligrams every day. Now, there's another drug that is mentioned as a preferred rhythm control drug in most of the guidelines, and that's sotalol. I and many people have used sotalol for this drug, but I would recommend that you should be very, very careful when you initiate sotalol, because sotalol is not your common garden antiarrhythmic drug. It has a definite association with torsades, and you need to be again very cautious when you prescribe sotalol, because there are umpteen examples when QTCs are not looked into, And and there will be at least 2 or 3% of your patients who have got multiple medical conditions, which may be prolonging the acuity and a casual and which may be easily missed in a routine OPD practice. Similarly, if the patient has hypertrophy, hypokalemia, all these increase the risk for sotalol toxicity. So be very careful when you prescribe sotalol as well. It's a preferred rhythm control drug, I agree, but a drug that has to be used very cautiously. And every time you escalate the dose, you have to monitor this patient closely and impress upon this patient the importance of getting these parameters checked time and again. Now, the second line drug is the easiest one, amiodarone. It's often used as a first line drug, but remember, this is not your first line drug because there are too many toxicities and we all know about it. And this is not something that you would like to prescribe every patient with atrial fibrillation. But yes, when you have coronary artery disease or you have hypertrophic cardiomyopathy or some of these other conditions, amiodarone becomes a drug, default drug. But then you should be questioning yourself whether I actually want to give amiodarone and would I prefer to rather use a rate control strategy. We don't have access to dofetilide, but dofetilide is again a great drug. But again, its problem is that it prolongs QT and it should not be used in patients who have got renal disorders. Now, if you were to compare the three drugs, which is amiodarone, propafenone, and sotalol, and this is a very old trial that was published, the CTAF trial from Canada, which showed that amiodarone was the more effective drug, although in terms of long-term effectiveness at 2 years, it was just above 60%, whereas both sotalol and propafenone did not do so well. The long-term effectiveness bordered from 35 to 40%. Although more patients on amiodarone had to discontinue their drugs because of drug issue-related toxicity. Now, there are two other drugs again, which are labeled as preferred rhythm control drugs in the guidelines, but these drugs are not available in India. One is dronedarone. Now, dronedarone is actually a good drug to have. It has been shown. It is one of the only drugs that has shown a reduction in risk of stroke and actually improved mortality in one of the trials when used in a dose of 400 milligram BD. But remember, it has a significant limitation that if you use it in patients who have got LV dysfunction or was significant heart failure, that is they're class 3 or class 4, or if they've got permanent atrial fibrillation, actually it can increase the chances of death. So therefore, dronedarone is a drug that you have to use very, very cautiously. And the same applies for diisopyramide. Diisopyramide was previously available, but it is no longer easily available with us. And this is another drug that can be used in patient for control of atrial fibrillation. The other advantage of both these drugs is, they are less likely to cause bradycardia. So in patients who have got AV nodal conduction disease or sinus nodal conduction disease, they are little more useful than flecainide, propafenone, or sotalol. So if you look at the current guidelines, whenever you decide a strategy for long-term rhythm control, you need to assess the baseline. Like we said, you assess the baseline risk factors. You may need to initiate upstream therapy, which includes ACE inhibitors, ARBs, MRAs, etc., in patients who have got the appropriate risk factors, because these are important modifiable factors that affect the recurrence of atrial fibrillation. But implicit within these guidelines, you can see, is that the reference to catheter ablation is always there. Therefore, when you decide a strategy for rhythm control, remember that it is implicit within your strategy that you will be considering catheter ablation when you want to keep this patient a choice for rhythm control strategy. Now, in patients who have got, there are a group of patients in our practice who have got infrequent occurrence of atrial fibrillation, and flecainide or propafenone used as a pill in the pocket approach is a reasonable technique. But remember, this technique requires that the first loading dose of flecainide or propafenone should be given in a hospital, because most of these patients have tolerated well, but you need to give it within the hospital. In fact, most of these episodes resolve within 1 to 2 hours. Within 2 hours, majority of patients convert to sinus rhythm. In fact, it's important to know that should you give nothing to a patient with paroxysmal atrial fibrillation, the probability that he'll convert to sinus rhythm within 24 hours on his own without any help from you is there would be there in half to two-thirds of your patients. Nearly 50 to 60% of your patients will spontaneously convert to sinus rhythm without the need for any pharmacotherapy. And within 48 hours, actually, it just increased marginally more to about 69%. So, which is why, in one of the studies that was recently published, it was, last year, we must have read it in NEJM. This was the RACE trial, RACE AVAX trial. And they looked at using an early or delayed cardioversion for patients with recent onset atrial fibrillation. And in early cardioversion strategies, they use either flecainide or electrical cardioversion. In delayed cardioversion strategy, what they did was that the patient who came with atrial fibrillation, they gave him a rate control drug, either a beta blocker or a calcium channel blocker. And if he was well, he was sent home within the first few hours. So his average time in the emergency may have been just a couple of hours. And then he was asked to come back and visit the physician in his clinic, not in the emergency, after about 1 to 2 days. And what they showed was that in the patients who were in, whether you were cardioverted early or you were cardioverted late, at the end of 1 month, nearly all the proportion of people who were in sinus rhythm was similar. In fact, if you look at the delayed cardioversion group, 70%, nearly 70% of them cardioverted on their own. A small fraction could be cardioverted with pharmacotherapy, and about 20-30 of them, percent of them were then DC-verted after 48 hours. So many atrial fibrillation can convert on their own. And which is and this is the other new trial that is on the block. And this was a trial. This is the East AFNet trial. And what this trial looked at was in patients who had got recent onset atrial fibrillation that happened, say, within the past 1 month, they randomized these patients to either a rhythm control strategy or a usual control strategy. And in the rhythm control strategy, patients were given various combinations of antiarrhythmic drugs, which was a combination of either flecainide, propafenone, or amiodarone or dronedarone. And what they showed was that when you use any of these antiarrhythmic drugs for these patients, and you looked at the proportion of patients who were in sinus rhythm at the end of 2 years, it was similar to the patients in sinus rhythm was significantly higher in patients who were on a rhythm control strategy versus patients who were in the usual control strategy. And this was the first trial, in fact, which showed that in patients who were given a rhythm control strategy, the probability of the composite endpoint of death, stroke, hospitalization for heart failure, or a hospitalization for acute coronary syndrome was significantly lower in patients who were randomized to an early rhythm control strategy. Now, remember that this study was done in a population that was about 70 years of age. And in this population, a rhythm control strategy seemed to do better. Whether this will work for a population that we see in our everyday practice, that is, a population that has an age profile of much younger people in the 50s or 60s, will it do as well? We're not so sure. But what is important to note is that, and that is why I put up the slide, was for you to understand the importance of the problems that you face when you go on a rhythm control strategy. And what this trial showed was that when you used a rhythm control strategy, there were significant side effects that were related to the use of antiarrhythmic drugs. And one was, obviously, there are some toxicity related to your drugs. But remember, many patients develop drug-induced bradycardia. Some of them develop AV block, and obviously some may develop torsades. And there may be other effects. These drugs may create hypotension. There may be increased hospitalizations because of problems of flecainide or propafenone causing fast heart rates, or other or even embolic events, which is why when you are using a rhythm control strategy employing antiarrhythmic drugs, be prepared that in the first, whenever you initiate such a strategy, one, your patients may require more attention from you than your patient who's going around without any antiarrhythmic drug. And the second thing is that these patients may end up with a pacemaker, because when you use these antiarrhythmics, powerful antiarrhythmic drugs, these drugs may uncover AV blocks, they may uncover sinus node conduction disease, and a small fraction of your patients may actually require pacemakers. So this is an important tenet in your strategy, that when you are counseling your patient for antiarrhythmic drugs, remember that you may have to resort to pacemakers in a small proportion of your patients. Now, there's 2-3 more slides that I will put up relating to your rhythm control strategy and how other things impact on your effect, on your you can say ability to control atrial fibrillation, is that we seem to downplay the fact that atrial fibrillation is actually a systemic disease. It is not only a arrhythmia. So you need to have a targeted look at all the risk factors that your patient has. Is this guy's hypertension well treated? Is his diabetes well treated? Am I addressing any OSA issues? Does he have alcohol? Smoking and physical activity are not so important in having the odds ratio of having atrial fibrillation, but yes, they can possibly impact other things that may affect atrial fibrillation management, which is important in your decision making, because upstream therapies are extremely important in making sure that atrial fibrillation is well treated. Remember that left atrial dilatation, left atrial remodeling is also a process that affects your outcomes. And this is why biomarkers are being used as of today to risk stratify in atrial patient with atrial fibrillation. In fact, this is an important. I thought this is something that would be interesting for you to know. That like we saw, that left atrial fibrosis is something that happens in patients with atrial fibrillation, and this is one of the newer targets for atrial fibrillation. What people showed was that there are certain microRNAs who are upregulated in patients who have atrial fibrillation, and these upregulations happen because these microRNAs are involved in the secretion of certain inflammatory markers, which lead to atrial remodeling, and that leads both electrical and structural remodeling, and that leads to left atrial fibrosis, which obviously promotes atrial fibrillation. So one of the new antiarrhythmic drugs in the future could possibly be an anti-inflammatory drug, and not truly an antiarrhythmic drug acting on the electrical nature of a cardiomyocyte. It may actually be acting on the inflammatory component of the cardiomyocyte. So I think this is, before we come to an end, just a couple, 2 slides more. Now this is a common garden arrhythmia that you see in your OPD practice. This is a patient who seems to be having a wide complex tachycardia, which is irregular. And I'm sure all of you would agree that this looks like something like a atrial fibrillation in a patient who has got a WPW syndrome. So this is a pre-excited tachycardia. So how would you like to manage this patient? Would you give him amiodarone? Would you give him lidocaine, adenosine, or none of the above? I guess because we don't have an odd, way to respond, I would like you to understand that the right answer in this would be actually none of the above. And why is that? That's because amiodarone has been shown, contrary to our everyday practice, to increase pathway conduction in a small group of people. And why that happens is that when you give amiodarone intravenously, it can actually act on the accessory pathway, and this on the AV node, the beta blocker effect can actually predominate, and the effect on the accessory pathway may actually be delayed. And in some patients, you can actually have it ventricular fibrillation or ventricular tachycardia because of amiodarone. So it is important for us to recognize that as of today, amiodarone is actually not, it is a class 3 drug in the treatment of pre-excited AF. The drug that we should actually be using is ibutylite. Ibutylite, I do recognize that it is not easily available, and most of us have not actually used ibutylite. But this is an important consideration that you should remember in your armamentarium when treating pre-excited atrial fibrillation. So I think I have more slides, but I think so I would like to conclude here and take any questions or uh, discuss any points that we would like to go forward with.
Thank you, Dr. Nitish. Um, Basically, atrial fibrillation is a long topic, and as we had discussed, the anticoagulation and other parameters can be taken up in the next session. So, Dr. Ankit, Dr. Anunay, and Dr. Sumod, if you have any pertinent questions, and so what do you think would be a practical approach for a fellow when they are sitting in the OPD? Like so many algorithms to remember, which one should they be choosing? Because everything, if you remember an algorithm, 13 algorithms for atrial fibrillation, it is practically not feasible. So what will be your do's and don'ts and simple tips that you should be using? As you had mentioned, that would you recommend a ABC algorithm, or would you still recommend that people use CHADVAS 2 score for risk stratification? And if yes, that what should be in India should be the current approach for atrial fibrillation as far as a fellow or physicians are concerned?
So, I mean, so the one thing we should recognize is that when you are seeing a patient who has got lone atrial fibrillation, this is a patient who has a fair chance, who's at paroxysmal atrial fibrillation, which is infrequent. Then a pill in the pocket approach is the best approach to this patient with atrial fibrillation, and you need not, start this patient on any drug, which is to be used for long term. The patient just continues as a pill in the pocket approach if this patient can actually be admitted. If this patient cannot be admitted during an episode of atrial fibrillation, then you would just let this patient be on no anticoagulation if his CHADS-VAS score is low, and you just follow him up till his first clinical episodes of atrial fibrillation, at which time you should be admitting him and exposing him to the oral flecainide therapy. I agree this is not something that is easy, but this is something that would be desirable. If on the other hand, the patient has been treated and has come back to you, and he's not in his acute episode of atrial fibrillation, you can start this patient on flecainide coupled with the beta blocker. How should I be assessing his risk of coronary artery disease or ischemic heart disease? Well, in patients who are, obviously below the coronary age group, no further assessment is required, but you might have to do a stress test or a CT angio to rule out any significant underlying ischemic heart disease. And that is generally sufficient. When in case you're doing a CT angio for this patient, then it is useful to also ask the radiologist to look at the left atrial size as well as left atrial appendage morphology. Although I agree this is not something that is there, this is largely the question of a research subject. Now, in terms of assessing the risk of stroke, the CHADS-VAS score as of today is sufficient. But there are many patients who would, whose echoes are large, whose LAs are big. In those patients, you cannot, do away with the fact that this patient has a risk for thromboembolism, and therefore, if you have got a large left atrium in a person who's hypertensive, and who's 50 and his CHADS-VAS score is low, then in those patients an ABC score would be better, because it is the low risk, the person with a seemingly low risk score whom you may be under assessing in your clinical practice. So that's where the importance of echo comes in very importantly, because at least you can assess the left atrial size and have an assessment of his realistic score uh, of his risk for thromboembolism.
Yes, Dr. Ankit, you were about to ask anything.
Yes.
There is another question that has come, that what is the quantum bioprosthetic valve with AF to be considered as non-valvular AF or not?
Well, a bioprosthetic valve can be considered as non-valvular AF, but not in the mitral position. In the mitral position, you should be considering them as rheumatic, the usual anticoagulation therapy. But in the aortic valve position, I don't think so there are any issues. Although guidelines continue to say that bioprosthetic valves can be treated if they do not have if they do not have any underlying mitral valve disease.
Sir, regarding subclinical atrial fibrillation, I want to ask something. So,
Yes, please.
yeah, you have told that subclinical AF more than 24-hour duration, those are having significant risk of stroke. But if a patient is having subclinical atrial fibrillation repeated episodes, but all the episodes are less than 24 hours, so these are equivalent, or should we should wait for when it is more than 24 hours, then only we can start?
So that is what I showed from that study, right? Like these, there is uncertainty in these trials as to the cumulative burden. What you're referring to is that, say, in 1 month, he has got 15 days with atrial fibrillation lasting 12 hours. And on another month, he has none. So does the cumulative burden of atrial fibrillation add up?
Yes.
So, there was previously some data to suggest that patients who had short episodes of AF and then reverted to sinus rhythm, those short episodes would actually increase the risk for of thrombus formation, because there was sudden stasis and then the sinus rhythm resumed, the left atrium would be stunned, and therefore these patients are at increased risk for atrial fibrillation. But in these trials, they have not been able to show that the risk of stroke was increased in patients who had got atrial fibrillation lasting less than 24 hours. The only thing that you need to monitor is that what are the chances that this patient progresses to atrial fibrillation in the future. Once this patient progresses to atrial fibrillation in the future, yes, this patient's risk would be high. Like we just saw, the CHADS-VAS score is equally important. For example, if this is happening in a 20-year-old with a CHADS-VAS score of, say, 0, then I wouldn't be worried, and I wouldn't, be too worried by repeated episodes of atrial fibrillation happening for durations less than 24 hours. But if the AF is happening for even shorter episodes, but in a patient who has got a higher CHADS-VAS score, say 3 or 4, then that would be something that would worry me more than the duration of atrial fibrillation.
Thank you, sir.
Dr.
Thank you, sir.
Yeah, please go ahead, Dr. Anand. Please.
Thank you, sir, for a nice presentation. I have two questions relevant for fellows. First, a patient comes to in our OPD with atrial fibrillation. How do we decide to go for rate control versus rhythm control? And second, if we go for rate control, we should have a lenient rate control, which we have to target 110, or a stricter rate control, means around 85.
Yeah, so for regarding your rate control, between tight rate control, which was there in race trial, showed that the patient, had a higher incidence of requirement for pacemakers. So I think the lenient rate control is something that would be better, rather than targeting a very tight rate control in many of these patients. And the decision for for embarking on a therapy for rhythm control is something that will vary from person to person. And why that varies is because how eager are we to incorporate a strategy for radiofrequency ablation in these patients. There are many patients who will just not stomach the fact that this patient, that I cannot afford, I would not like to take a chance for any complications are arising out of rhythm control strategy that includes catheter ablation. So when you put in that factor, I guess you suddenly become a little less aggressive in your rhythm control strategy, because antiarrhythmic drugs for very long periods of time are something that is not very clear. That can I give a propafenone or flecainide for years together. But yes, in very young people, who are in their 20s and 30s who present with atrial fibrillation, I would suggest that you try two antiarrhythmic drugs. And if that fails, then you should be referring this patient for AF ablation. In a person who's in the 70s and 80s, in them, the decision for rate control or rhythm control would again depend upon the degree of his symptoms. And if symptoms are mild, then I would guess that, you wouldn't like to start a rhythm control strategy, because over there, the probability of having complications because of rhythm control strategy would be something that the patient is ready for. That's why if you look at all these guidelines, they are very nebulous in their advice, and everywhere it becomes patient preference, patient and all this tolerability, acceptability comes in. Most of the trials that you saw in which a catheter ablation was done were European centers that were doing catheter ablation routinely. And in India, there are not many centers that routinely perform catheter ablation. So I guess you need to factor in all these issues when you are planning a rhythm control strategy.
Thank you, sir.
Yes, Sumod, you are muted. If you can unmute yourself, Sumod.
Lot of patients of rheumatic heart disease on only on rate control strategy. So what is the when should we consider to convert them to normocenterism? What are those patients in which either by decibation or antiarrhythmic drug? Is there any patient whom we should consider like that?
So, we had done one study in which patients with rheumatic heart disease who had got atrial fibrillation, and we gave them flecainide. And we saw patients who had got mild to moderate lesions actually did reasonably well when they were given flecainide therapy. So, but the other study that we have done is that in patients who got rheumatic heart disease and mild to moderate valvular lesions and who have got atrial fibrillation, we did a strategy of antiarrhythmic drug coupled with DC version. So again, if you look at these strategies, the probability that you'll maintain sinus rhythm at the end of 1 year would be to the tune of about at the end of 2 years is about 30%, about 60% or so. In 30 to 40% of the patients, they lapse back, and then you need to let go of the strategy. So if you want to pursue the strategy, remember it has to be done aggressively, and it is something that is time consuming. There are many patients who are young. Now, if you look at your own profile of patients who have got rheumatic heart disease with, say, mitral valve disease, many of them are young because they present very early. In these patients, an early intervention of the mitral valve and a rhythm control strategy is what you should be looking at.
Sir, you have mentioned that we can't use amiodarone with AF with WPW.
Yeah, that's something we routinely use even as of today, that patients who present to the emergency are often given amiodarone, and amiodarone is being used, but remember the concerns that I showed, that you can have patients who develop VF or ventricular tachyarrhythmia with amiodarone. So as of now, it is not in the guideline, it's actually class 3. But I agree, because we do not have access to ibutylide in most centers, we are still continuing to use amiodarone.
Dr. Nitish, are there any studies of atrial fibrillation from India, otherwise, as far as the epidemiology or the estimates of the burden are concerned? Just a rough estimate or any particular details, etc.
I think so. We have had some studies that were done from IHRS, which were done in small population that looked at AF burden. And again, they showed that as the age increases in ages beyond 65 to 75, the incidence was 2 to 4%. But, these were not actually the screening done. These were screening done as opportunistic screening. if you look at screening studies as of today, that look at burden of atrial fibrillation, the main limitation is that the AF is just assessed at one point. And now we will get much better data because majority of the trials that are currently being performed, looking at the epidemiology of atrial fibrillation, are using variables. So these studies are going to come out in the next few years. There are at least 4 or 5 major trials that are employing variables to look at atrial fibrillation. And therefore, because atrial fibrillation is not a yes or no arrhythmia, it is something that will be there in many people. So that's how, the burden of atrial fibrillation may be high, but the contribution will vary depending upon the underlying clinical condition.
Two last quick questions actually. Dr. Sanjeev Katuria is asking that what are the comments on high power short duration of ablation therapy, as far as, though this is not actually the detailed topic of concern, but
Yeah,
word.
I know.
Yeah.
I mean, I have not had any personal experience with that sort of strategy, but that is something that would be very important in current day practice, because what you can see is that many of the atrial fibrillation that we see are not only paroxysmal, they are persistent. And therefore, when you have to look at rotors that are there on the posterior wall of the left atrium, the problem with the conventional radio frequency ablation technique is that you may cause an esophageoatrial fistula. When you use high power short duration, you can practically continuously spray the left atrial posterior wall, where a lot of rotors would be lying outside the pulmonary antrum. So pulmonary vein antrum. So this strategy is something that has significantly been useful in many studies, and this is something under uh, being prospectively evaluated as well.
Mitral valve prolapse and atrial fibrillation. Any difference in the approach that you would be having? Dr. RK from Bangalore is asking.
Yes, I mean, regardless of the etiology of mitral regurgitation, um, uh, the left atrial volumes and dilatation will contribute to atrial fibrillation occurrence. The In fact, the degree of mitral regurgitation also is an important correlate of about the chances of atrial fibrillation. So this is in fact, so if any patient with MVP or MR who has even moderate degrees of echocardiographic regurgitation, if he develops atrial fibrillation, that is an indication for intervention, because even if your echocardiographic evidence is 20% or more, is only moderate, then the importance of atrial fibrillation is that it indicates that there is sufficient electrical left atrial remodeling, which can impact long-term outcomes. So atrial tachyarrhythmias in a patient with even moderate valvular lesions is an indication for valve replacement or valve repair.
One more thing, sir. As we monitor our anticoagulant therapy in AF with the TAD score, is it something different in thyrotoxicosis? As I read once, in thyrotoxicosis, you have to go for an anticoagulation even if the TAD score is not high. It's one of the conditions where it becomes independent. Is it so? I read it somewhere, I don't remember. It was one of the good articles, only review articles. But is it that in thyrotoxicosis, we don't tend to take the TAD score into consideration?
I mean, see, specific conditions like thyrotoxicosis, you would again like to do, if you are able to correct the thyrotoxicosis, the atrial fibrillation should subside on its own. So, there is a clear inciting factor for atrial fibrillation. And if you do away with that factor, the atrial fibrillation should resolve. There are other conditions in which atrial fibrillation happens as a part of disease, for example, in athletes and in tumors and other conditions. And in all these things, these are neurogenic atrial fibrillation, or they are inflammatory atrial fibrillation. Over there, like we just discussed, we don't have clear guidelines for specific conditions. For example, if you have an athlete who's running a lot and he has AF, how should you be looking at this patient? Because if he has long episodes of AF, left atrial dilatation, he may have an athlete's heart, he may have LVH. Do I change my strategy because the CHA2DS2-VASc score will be low, but other parameters which are there in the ABC score or other clinical risk score like the Garfield score may be high. So that is where there is a degree of uncertainty. So I would say that you would still need to go by the CHA2DS2-VASc score only to assess the risk of stroke as of today.
And in a rate control rhythm, so is it that one of the calcium channel blockers is any calcium channel blocker preferred over the other, or is it that we consider all the blockers, beta blocker and calcium channel blocker in the same podium?
I mean, any of the non-dihydropyridine blockers are equally effective. Amongst them, verapamil has a greater effect on the AV node than diltiazem, but that may vary from person to person. And beta blockers are generally more effective for for patients who are having exercise-related higher upper rate. So the only difference is comes out between them is in the presence or absence of structural heart disease. If there is structural heart disease, then you would clearly prefer a beta blocker. But if there's no structural heart disease, then there's no reason to there can be no compelling indication to choose a beta blocker over a calcium channel blocker unless a calcium channel blocker is less effective in controlling exercise related fast heart rates, at which point beta blockers might be slightly better.
Well, thank you, sir, and so much for this excellent lecture as usual. And I know that atrial fibrillation, as we had earlier discussed, is not a 1 hour job. It requires series of sessions. And as you had nicely summarized, just for all the fellows and our physicians, starting with the atrial fibrillation, the 4S approach, determining the stroke risk. How do we determine the stroke risk, and how do we estimate what are the various approaches, CHA2DS2 score, then the ABC approach, then taking on the rhythm versus rate, summarizing the latest trials on rate versus rhythm, including the East Ended of trial, which has been recently published, and what are the appropriate drugs for rhythm control, was nicely summarized by Dr. Nitish Naik. And then we'll be coming back with further sessions on the anticoagulation therapy, NOACs versus warfarin in the next session along with Dr. Nitish Naik, if he permits us to, so that we can wind up with this atrial fibrillation comprehensively. But thank you so much, sir, for joining and giving us a comprehensive overview of atrial fibrillation. I know that many of you would like to ask for this repetitive lecture, the recording of this, which will be available on our YouTube channel from tomorrow, and I'll be forwarding the link to you. And thank you, Dr. Sumodh, Dr. Sanjeev, Dr. Anunay, and Dr. Ankit Bansal. And thank you, Dr. Nitish Naik. Thank you, INTAS, for providing us this academic platform. Next week, we'll be presenting again a wonderful session for you, which I'll be sharing. The details will be sharing soon with you. Thank you so much, and have a great day and a great evening. Goodbye.
Thank you,
Thank you, sir.
Thank you
Thank you,
very
sir.
much.
Thank you,
Thank
sir.
you, sir. Thank you.